I have 11:30 exactly. Should we get started then? See lots of nodding heads. Okay. Hopefully now, for those of you who are signed into the session, that Q&A has gone active. It's gone live for you. Again, we're asking for people to please type into the Q&A. Tell us about why you chose to come to this session, what it is you want to get out of our time together today, what it is you want to learn. We would really appreciate hearing about that. And before we really get rolling with things, let's go ahead and have the presenters introduce themselves. So I'll go ahead and I'll call on Stacy to introduce herself.
Hi, I'm Stacy Enders. I am a positive supports policy analyst and external program review committee coordinator for the Department of Human Services Disability Services Division in Minnesota.
All right.
Liz, do you want to go next?
Oh, thank you.
Hi there, I'm Liz Harri-Dennis. I am the Person-Centered and Positive Behavior Support Specialist on our Community Capacity and Positive Supports team at the state of Minnesota, and I'm also a board certified behavior analyst. Amber.
Hello, I'm Amber Maki. I also work at the Department of Human Services in Minnesota, the Disability Services Division. I'm also a board certified behavior analyst, and I work on the same team with Elizabeth, Stacy, and Mary. And Dr. Piggott, would you like to go next?
Thanks. I'm Mary Piggott, and I work for the state of Minnesota in the Disability Services Division. And I'm on the same team as everybody else here. And looking forward to the presentation today.
All right, awesome. And then for our session host, any info get chatted in or typed in yet?
We don't have anything yet, but I'll let you guys know if we get any answers.
All right, fantastic. Well, welcome everybody to our session. We're going to cover today the experience that we've had in Minnesota trying to build capacity around person-centered positive behavior support practices statewide. Stacey, if you want to go to the next slide. So we're going to start, and we've already done the first agenda item with introductions. We're going to get into some discussion about the effect of policy changes on restrictive procedures, how to go about doing that, and what we've seen as a result of building in certain rules and statutes across service delivery in Minnesota. We'll talk about what's currently going on in our state and some next steps. And we also have some resources we can share with everybody at the end, or that you can just have for reference if you've downloaded the PowerPoint deck. All right, Stacey, next slide. Liz, you're muted.
Man, doesn't matter how late it is into the pandemic, that still happens. All right, so the brackets around our presentation today are connecting back to the literature of implementation science. And it makes more sense for us to show how we look at implementations rather than just tell you. So I'm gonna give just a brief overview and then come back to this connection to the literature at the end. When we talk about implementation science, we're talking about that science to service gap, and that what works in research and evidence-based practices gets lost in the real world where there are less controlled environments. Fixin' It All 2013 is a nice summary of how implementation science addresses this gap. There's kind of three chunks to it. You can either let it happen, help it happen, or make it happen. So our team on this community capacity and positive supports at the state of Minnesota, we're accountable for making it happen. And we found out a lot in the last few years about what works. So Fixin' It All talks about the importance of the practice to policy communication loop, where state management teams hear frequently about what's helping or hindering efforts of evidence-based practices in the field. But our question is, what happens now, just a few years later, when government agencies have added professionals who have backgrounds in positive supports to their ranks? Do folks in policy have anything to add to this discussion? Is it like the proverbial iceberg where there's more below the surface than above? So there's two places in Fixin' It All where we feel like we can add to the discussion. And again, I'll be coming back to this at the end on the theoretical basis of implementation science. First, where Fixin' It All state implementation members have special expertise regarding evidence-based programs, implementation science and practice, improvement cycles, and organization and system change methods. So we have partners with this expertise, and we're going to chat about our partnerships today, but also our ability as a team to assess the system beyond just positive supports policy and evidence-based practices to how we support what we call capacity for our practitioners on the ground to be able to do the work that's really important. So you're going to hear some examples of how we support positive supports within our role in government. The second piece of Fixing It All that we want to come back to is where they write, if evidence-based programs are not being implemented reliably to produce effective outcomes, there's nothing useful to scale up in a state. We want to look at this a little bit differently. Building our ability to assess and understand what is actually happening and working across silos and the variables that affect capacity are really important. And so we're going to talk about some ways that we do this. So I'm going to hand it over to Amber to start our story, and I'll come back to this discussion at the end.
All right, very cool. Before I jump ahead into this slide here, there was one response for why somebody is attending our session, and they said one of the participants says they are attending because person-centered interventions piqued my interest. So cool. I hope we keep your interest. I think we will with what we've got planned here today. So thank you so much for sharing that. So before we jump into a lot of the details around specific policies, statutes, projects, capacity building interventions that we're working on, we want to set the historical context so people have an understanding of the environment kind of in Minnesota for getting away from restrictive procedures, which we define as things like emergency use of manual restraint, restraint and seclusion, using restraint chairs or other devices that might limit the person's access to their body or that they can't take off themselves. So transitioning away from that to positive supports, which in the state of Minnesota, we do define pretty broadly to include positive behavior support, person-centered practices, and a whole other host of practices like cognitive behavior therapy would be another one. Wraparound planning would be another. So our history goes back into the late 1940s with Governor Luther Youngdahl burning straitjackets outside of one of the state hospitals. When I first learned about this, I was blown away. The governor, and if you can see the picture there in the upper left-hand corner, that's not a small bonfire. That's a pretty big raging fire that he had there. And I remember seeing this thinking, this guy's radical. Holy smokes. So he declared on this day, nobody in the state of Minnesota shall ever experience these kind of restraints ever again. I would like to know, and I'll keep going, but please in the Q&A chat in, what do you think happened the very next day in that state hospital when it came to trying to support somebody engaging in really dangerous behavior to themselves or others? So use the Q&A. Tell us, what do you think happened after he burned those straitjackets the very next day? So moving along in our timeline, Minnesota's had several lawsuits brought against it for unjust use of institutionalization and segregation of people with disabilities. And the first one that we have here is the Welsh Consent Decree. And that was really having people remain in institutionalized settings without the option for a community-based living setting. And through that litigation and settlement, we started closing down our institutions and creating more community-based options. With those community-based options, 1987, we had a rule, we called it a Rule 40, for governing aversive and deprivation procedures, specifically with people with intellectual developmental disabilities. And what that rule looked at was getting approval for the use of things like arm limiters, restraint chairs, helmets, seclusion rooms built within a home. And the issues around using that is that once people got onto what was called a Rule 40 program, they typically didn't get off of that program. What we know about the use of punitive procedures is they tend to be reinforcing for those who use them, right? So there are people on these programs for 15, 20 years and not really being phased off of that. In 2008, we had another lawsuit brought against us for improper use of restraint in another institutional-based setting. And it's called the Jensen Settlement Agreement. And from that, we really revolutionized all of our rules governing community-based services, especially with regards to people with intellectual developmental disabilities. But it does affect a broader range of people, from older adults to young children, in that we've built in rules and laws requiring the use of person-centered practices in supports for people using supports, and the use of positive supports of other types, including positive behavior supports. So no longer do we have to spend a lot of time trying to convince people, this is really, you got to do this, you got to try this, just trust me, just come along with me. It's saved a ton of time in that, hey, you got to do it now. So let's figure out how we're going to go about doing this. So with that, do we have a answer from the audience? Okay, so for my earlier question, when the governor burned all those straitjackets, either they found more jackets or someone dies to an inaccurately applied restraint. I don't know about anybody passing away, but absolutely the nurses had, taken some of those restraints and hidden them away so they didn't make their way into the bonfire. So those options, we can't just take those options away from people and expect them to then have a replacement skill, right? So a lot of the rules and things we're going to cover here today is about, instead of using those punitive procedures, here's what you do instead. And we're going to help you figure this out. Great answer. Thanks so much for chatting in. Okay, I think it goes back to Liz.
Yep, and I unmuted successfully here. So yeah, building off of what Amber was just saying, between 2011 and 2015, what was done was then different than a copy and paste for best practices or a program. So Minnesota was really charged with making positive supports the law of the land, but how do you legislate positive supports? So what we did is we had an advisory committee come together consisting of advocates, professionals, parents, and other folks to inform this process. And they had the foresight to focus on values as a way to drive this process. So I think it was mentioned earlier in one of the copy chats that we don't really focus on positive behavior supports, but you've heard Amber talk about positive supports as this broader term that encompasses person-centered practices, and you can see in the headings here some of the things that really are a part of what we call positive supports as respect of persons, human rights of persons, best practices, and quality of life. And so these values became codified in the statutes and rules that govern this practice. So our statutes, which we call 245D and the positive supports rule, legislate some of the items that you see here for people with IDD living in the community. So if you go to the next slide, the other place where they had a lot of foresight is also recommending that these values be upheld in the implementation process, planning, design, and execution. So we're going to get to some more about acknowledging some of these real world challenges and how we've done it. But the three here that's become really important in what we do, and I think is really what led to the development of our team and us having a role in government to really provide some help in implementing positive supports is that there was a role for folks to provide technical assistance to providers rather than punishing them. And that's a huge part of what we do. We also are looking for ways to acknowledge and address real world challenges, including limited funding. And you're going to hear some more about how we address workforce issues. And then our statewide and system-wide training of permitted techniques and teaching alternative behaviors. And we're going to talk about that some more with how we partner with our folks at ICI at the U of M. So if you go to the next slide here, there's a lot here, but it's really, this is the infrastructure that was set up then by this legislature. And it's kind of set up by each different system that it applies to. And so, but I want to step back a second and go, well, why legislate though? Why even legislate in the first place? Can't we just like train people and spread this good practice? You needed that legislation to give state agencies authority to oversee these positive supports. And this was needed due to those lawsuits that Amber mentioned. People were being hurt. And so it was decided in the state of Minnesota that it's the role of government here to protect people from harm and to promote best practices. And that's what's really, really unique about our statute, is not just to limit certain statutes, but also to promote those best practices. So here's where you can see, you can pull out different parts of where these values are in every system in the state. There's two parts of the law that kind of oversee that in our Olmstead plan, and also in our statewide plan, where they're looking at things and they've legislated to make sure that positive supports and quality of life are things that are looked at. For our service providers, they have to use positive support practices and they have to use best practices. And they also mention APBS, by the way, as a place to look for those best practices, as well as quality of life. And lead agencies, which are our counties and tribes, because we consider tribes are sovereign governments, and so we partner with them, and they also provide some oversight as far as helping us with making sure that these things are happening in the community. So Stacy's going to dive a little bit deeper into 245D and the positive supports rule, as the oversight of this legislation is really a key role in our team.
All right, thanks, Liz. So in these next two slides, I'm going to talk about two of our laws that were implemented in Minnesota in response to the Jensen settlement that Amber mentioned earlier. The laws, they cover a lot of different topics, but primarily they focus on reducing the use of restrictive procedures, such as like mechanical restraint or manual restraint or seclusion. And then also, like Liz was saying, also increasing the use of positive supports and person-centered practices. So the first one I'm going to talk about today is what we call Minnesota Statute 245D. So at the system level, this law restricts the use of things like mechanical restraint, seclusion, manual restraint, and several other procedures, except in life-threatening situations. So one example is the law allows emergency manual restraint to be used to intervene when a person is at imminent risk of harm. Another example is that restraint can be used when a licensed healthcare professional needs to safely conduct a medical examination or provide medical treatment. But for the most part, restraint is prohibited, or they need additional approvals or need to do additional reporting if they're going to be using restraint. At the group and organizational level, we have additional training requirements now for all staff that include things like principles of person-centered service planning, helping people exercise their rights, and other topics that are related to positive supports and person-centered planning or person-centered practices. We've also added increased training for certain types of positions. So one example is we have a position that's called a qualified professional, and those are people who typically write our positive support plans, so they have to have additional training and educational requirements. And then in addition to the training that providers usually provide to their staff, we also offer a lot of training and technical assistance from the state for providers that are trying to implement the policies that we have outlined in 245D. And then we also provide things like example forms. So service providers have to sometimes develop their own internal policies. So we have examples for them to help them develop those policies. At the individual level, we don't require person-centered planning, but we do use language to strongly encourage it. And then we also provide funding, because that's really important through the waiver services to make sure that, you know, if they're going to do a person-centered plan, that we have a way for them to pay for it. And one thing we do require also is a positive support transition plan, which is a very specific type of form in Minnesota, which needs to be used whenever someone is put in restraints or used repeatedly. And then we also have standards requiring support teams to work together as a group to look at when they're using restraint. They need to work as a group to try to figure out, you know, what is a way that we can prevent this in the future and make sure that this restraint doesn't keep being used. Another law we have in Minnesota, we call, it's called the Positive Sports Rule, but it's actually Minnesota Rule 9544. And this rule, again, has a variety of parts, but I'm gonna focus on just a few areas of this. And one thing that you might find really interesting is that our law actually specifically calls out APBS as one of the references for professional standards. Another part of this rule requires service providers to report certain incidents of behavior interventions. And then what we do with that information, we have it listed here as a behavior intervention reporting form. What we do is we use that data to make decisions about our work priorities. So we look at the trends and we look at use, and then we try to figure out, you know, what are the things that we need to do next. And then we also have a review committee that helps us with this work. And I'm not going to get into that right now, but I will tell you about it a little bit later in the slideshow. At the group and organizational level, we created a variety of resources and training that follow the rule. And then they also expand on topics that are not covered in the rule. So one example is we have a guidelines document that we have linked at the end of the slideshow if you want to take a closer look. But that explains things like how to collect data, or what are some examples of positive supports, or what are positive interventions and things that wouldn't necessarily be appropriate for us to write into a law, but are things that we would like to see providers doing. And then we also have a couple web pages that give information on positive supports and person-centered practices. The one example here, the person-centered webpage resource that has a lot of different things, but one thing that I've found really useful and the teams have said they really enjoy is there's a regional listing of person-centered planners in the state. So someone can look up, if they want to find someone local that can help them to write a person-centered plan and to go through that entire process with them and help on an ongoing basis, they can look up, they can find someone in their area. At the individual level, we provide one-on-one technical assistance when teams are struggling to reduce the use of restraint. And then also at the individual level, the rule requires that a functional behavior assessment be conducted whenever a professional develops or modifies a written intervention. And then the law on that is somewhat vague, so we created some optional quality checklists for the assessment and also for the positive support transition plan because the rule doesn't provide a lot of detail on those documents. So we have these optional tools that they can use to check the quality of their work. So on this next slide, what we have here is some data on one of the forms that became required on the positive supports rule is the behavior intervention reporting form, which we also call the BIRF. So the BIRF is primarily used to report the use of restraint. And then you'll see here that we've had a steady decline since the implementation of the positive supports rule. So looking at 2014 till now. However, you're going to see later in this presentation that other types of data we collect show increasing trends and things that we don't want to see. For example, service terminations have been increasing. So what we're finding is that it's really important for us to look at a variety of data and to get a sense of how our policies are working, and then making those connections with people and having those conversations to see, are these policies working for the person at the individual level? And are they really improving lives? But we're going to talk more about that in a little bit later in our slideshow. All right, now I'm going to hand it off to Mary.
Okay, I'm unmuted. I'm going to be talking to you about the person-centered practices and positive behavior support strategies that we use in Minnesota and how we're collaborating with other agencies around the state to provide these services. They include things like a statewide plan for positive supports, collaborative safety, centers of excellence, person-centered thinking, technical assistance, and an external program review committee. We have a collaborative partnership with Minnesota Positive Behavior Support Network, which is part of APBS. And we also have a relationship with the University of Minnesota and with the Institute on Community Integration and the Minnesota Department of Education. Within the Minnesota PBS network, we've developed a collaborators forum on PBS topics that's offered quarterly around the state. We work on policies and procedures such as standards for PBS in Minnesota. And we're working at defining what positive behavior support in Minnesota looks like and what our values are as a state. With the U of M Institute on Community Integration, we work a lot with Rachel Freeman and her colleagues across several projects. For the past 5 years, we've developed 5 cohorts around the state and provided them with a foundation in positive behavior support and person-centered practices. There's a statewide plan for positive behavior support, and we're developing centers of excellence around the state that will further expand and develop the original cohort model. We've brought person-centered thinking and picture of a life training into the state and developed strong mentors, coaches, and trainings that are ongoing. And we partner with the Department of Education to bring person-centered thinking skills and picture of a life training to schools, teachers, and parents. We're also doing Charting the Life course, Ambassador Series, with the Department of Employment and Economic Development. And we're always looking for ways that we can further embed person-centered thinking and charting the life course within the work that we do. Next slide. Our focus here is on our role in government and how we've exercised creativity and judgment around that. As I've said, much of our work is in collaboration with the U of M, Minnesota PBS Network, and the Department of Ed. We have a contract with the University of Minnesota where we're working with Rachel Freeman and the work that she has done in statewide practices in person-centered planning and positive behavior support. There is a link on this page to an article she wrote about the process for you to review. At the systems level, we have cross collaboration with education, corrections, mental health, and other agencies. We have staff with an active role in Minnesota PBS Network. In collaboration with the Institute on Community Integration, we have the Minnesota PBS website. And we have certified person-centered thinking and picture of life and charting the life course trainers that offer training across the state, targeting areas that have high needs for training. At the group and organizational level, we have the 5 cohorts that are spread around the state, the development of standards of practice for person-centered planning and standards of practice for positive behavior support. At the individual level, we have the PBS Intensive Series, which is done in collaboration with ICI, training providers around the state on the basics of positive behavior support and systems change around those efforts. We have person-centered thinking and planning training, as well as charting the life courses. And now I'm going to hand it off to Amber to talk more about the technical assistance.
All right. Go ahead and go to the next slide, Stacey. So we wanted to build in a way to connect with county case managers who are leading service planning efforts across the state and connect with service providers who are now required to implement these rules and policies. So we created an infrastructure for providing technical assistance to people, a way to email, connect with us, for us to use any sort of reporting data that providers have to send in to us to connect with them as well. So we monitor a variety of things. And here we have some data on our residential, so think group home, service suspension. So that means the person maybe was arrested or brought to the hospital. They're basically not in the home and their services have been suspended. And then the termination, where the provider has made the determination they can no longer keep the person or others in the home safe. And so the person needs to basically end their residential service agreement with that provider and move out. So since a lot of the rules were promulgated and really came online in 2015, 2016, we made this requirement that providers report to the commissioner or notify the commissioner when they're suspending or terminating residential services. And we do see this increasing trend in those notices following the implementation of these new rules and laws and requirements, meaning it's a struggle. There's a good reason we have the technical assistance infrastructure in place and that we are doing all the work that we're doing and trying to reach people and support these efforts across the state. Interesting note here, when COVID-19 first really came about this time last year, we all kind of questioned, are we going to see more use of manual restraint, around power struggles with wearing masks and not leaving the home and all these other things that were geared around keeping people healthy and safe. And I think it's safe to say we kind of saw the opposite. So we're trying to kind of noodle on this and figure this out. What is contributing to some of these positive results from COVID-19, forcing everybody to kind of change habits and routines, that we've seen a huge decline in residential service termination and suspension notices. So just a little interesting tidbit there for folks. Go ahead and go to the next slide. So we wanted to share some of our statewide data. This comes from our National Core Indicator survey that the state of Minnesota participates in. I believe I saw there's 45 states in the union that participate in the NCI survey. And this helps when we're looking at our work to see that statewide, 10,000 foot perspective. So part of the work we're doing is we're looking at various layers of data and impact, and where is there need, and where are we seeing things crop up, where are we seeing successes. Stacy, if you want to go to the next slide. This also came from the National Core Indicators, but it's a nice way to look at if people are taking medication for challenging behavior, do they have a support plan in place? And we can see how Minnesota compares to the nation. So again, this is just a way to look at that state level data. Go ahead and go to the next. Really interesting recent work that we've done. Also, again, kind of created a necessity because of COVID-19. Providers in the state of Minnesota can contact their 245D licensors. So the people who oversee their programs and monitor for compliance. But our 245D licensing division, they don't look at quality, right? And they know a little something to kind of help advise providers on what to do. So we created a partnership with licensing to deliver some informational webinars, some sessions where they can speak to what people have to do, and our team can bring in the expertise on how you can go about doing it and where you can find resources to learn more. And we provided or gave attendees evaluation forms after each, and we converted the scores for each of the sessions into the standard grading scale, just to see how responsive we were being to people's needs. And based on the feedback we got, we made changes and improvements, and you can see how our grade has increased over time. So just wanted to share how when we work across divisions, work across silos, and are attentive to the audience needs, how we see these positive responses, and people come back to learn more. They start to contact some reinforcement with this stuff. Go ahead and go to the next slide. I think this is you, Stacy.
Sorry, I'm gonna mute myself. All right, so as I mentioned before, we have a committee that helps us with all this work, and we call it the External Program Review Committee, or we also call it the EPRC. So this committee has a few state staff on it, us you see here, and then a couple more people that weren't able to join us today. But the majority of the members on the committee are private providers who either do direct care and disability services or they're medical professionals. And what they do generally can be wrapped up into three major activities. So the first activity they do is they review the majority of our BERFs, and those are the behavior intervention reporting forms. And then they contact providers directly to offer them technical assistance. And we even meet with teams in person, well, before COVID and then after COVID, we'll meet with them in person to help them if they need that level of assistance. They also review requests for mechanical restraint, and they provide recommendations to the commissioner to either approve or deny those requests for mechanical restraint. And then part of that work is also providing that technical assistance to providers who make the requests, and then helping them develop alternative positive support strategies to replace the use of the mechanical restraint. And then the third thing they do is they provide general guidance to the Department of Human Services on how to increase the use of positive supports. So one example is we're working on a medication manual right now, and they're helping us develop that and edit it, and then hopefully we'll be able to publish it later this year or next year. So this committee was actually written into our laws because the advocates wanted to make sure that our division has ongoing guidance from positive support experts. And one of the unexpected benefits of this committee is that it's actually relatively cheap to run. So all the members on the committee work part-time because they all have jobs in disability services, and a lot of their work is done electronically. So it's actually a really practical way to infuse positive support expertise into our state government. And then it also helps to build trust because so many of our members are actually working in the field and they're supporting people on a day-to-day basis. So if anyone listening today, if they have any interest in setting up something like this in their own state, please feel free to email us. We have our email on the last slide. We'd be happy to give you some more information about them. Another thing that we do to help providers is we have forms that guide supports. So as I mentioned before, the EPRC, they read the behavior intervention reporting form, and that gives them an indication of when a provider might need assistance from them. And then we also use that form and other forms to direct the provider actions. So one example in the BERF is that one of our questions is it asks teams to explain how they will avoid future uses of the intervention. And when I say intervention, I mean things like manual restraint or mechanical restraint. And so that hopefully having that question in there encourages the teams to come up with a plan. Or if we see that maybe there's nothing in the box, or maybe the plan that they put in there isn't likely to work, we have an indication on our end of when we need to reach out and offer that team some assistance. We also have other forms, like I mentioned, the positive support transition plan, and then it has a related quarterly review form that we use to guide service providers through the process of phasing out the use of restraint. So these forms are mentioned in rule, but then our law actually states that the content should be determined by the commissioner. And that's a really nice thing about, a really nice way to write policy, because forms are easier to change than it is to change a law. So if we need to make a quick change, or if we get feedback from providers and they say, this is not working for us, we need to make those edits. Using forms in this way as policy is actually really helpful. And it's more timely too. And to give you an idea of the positive support transition plan, I'll just go over it real quickly. We do have it linked at the end of the slideshow, but basically it talks about the person's information. Then we talk about quality of life, because we found that improving a person's quality of life has a really big impact in reducing the use of behaviors. And then we talk about, the next section is about the behaviors that they want to phase out. And then we talk about the behaviors, the procedures and then the behaviors. And one thing that we added this year is we now have a section on desired alternative behaviors, because as Amber or Liz was mentioning earlier, we found that you can't get rid of those interfering behaviors until the person has a way to get the thing that they need. So we now have a desired alternative behavior section that we added just back in January. And then we have the crisis framework that we have at the end of the form, where they talk about, when the person's in crisis, what do you do? When they encounter a trigger, what do you do? And the provider can go through that process and outline, what are the actions that they're going to take. So if you're interested in taking a look at that, it's linked at the end of the slideshow. We also recently published some quality of life tools. And I know that there are a lot of quality of life tools available. You can do a Google search and come up with 1,000 of them. But one thing that's unique about the ones that we just published is they're similar. They have similar topics and questions, but one is written in a way for the person to fill out, but then the other one is written for providers to use when the person is unable to tell people what they need or what they want. So maybe they're unable to communicate their needs, and maybe even with a device, they're not able to tell people what they want in their life. So the form is written in a way that providers can observe their behaviors, or they can observe things like, does the person have a person-centered plan in their coordinated service and support plan? So it tries to avoid making any assumptions about what the person thinks or how they feel, and it actually has really concrete things that you can observe. So if you'd like to take a look at those are also linked at the end of our slideshow. And then we have the quality checklist, which I'm going to get to on the next slide here. So we have 2 quality checklists. Our first one is the functional behavior assessment quality checklist. And this is an optional tool, but we found that it can be really helpful in implementing our policies, because it gives care teams more information about functional behavior assessments, and then it gives them some criteria and information on how to check the quality of their work. So I'm not going to go through the entire tool. Again, it's linked at the end of the slideshow, but some examples are we give them information like on how to collect context, antecedent, behavior, and consequence, that CABC data. And then we also give them some guidance on how to write a hypothesis statement. So if someone's new to writing an FBA, they have some more information here that wouldn't really be appropriate to put in a policy or in a law, but we do have resources for the providers. The other one is the positive support transition plan quality checklist. And this one functions in a similar way to the functional behavior assessment quality checklist. And one of the nice things about this tool is that we can use it on our end to provide consistency in our own work. So the external program review committee, they often use this form when they're following up with care teams. And that's a way our state representatives have some level of consistency in how they're responding to those care teams. So we don't have one member telling providers one thing and another member telling providers something else. So we found it really helpful just for us to do our own work as well. And so here we have an example where we bring all these policies and these resources together, and we look at them, at the individual level. Is this working for someone? And how did it impact that person? So at the left, you see the baseline. The person was being restrained at a pretty high frequency and also for a pretty long time, 140 minutes, just in the month of May. And then in the next section, their team implemented a functional behavior assessment and a positive support transition plan, because we do require that in our laws, that they do that. So they implemented the plans, things went down, it started looking better, then school started, and the person was being restrained more often again. So at that point, Amber and I, we went out and we met with the team and we started providing our technical assistance. And then you see in the next section that after we were able to help them, give them some tips, we used those quality checklists to go over their plans with them. And we did see a decrease in the use of restraint after that. And we only did 2018 through on this presentation here, but I looked at 2020 data, and this person was only restrained 3 times in the year 2020, and it was for less than 30 minutes for the entire year. So a massive reduction in the use of restraint for this person. Amber, did you want to add anything to this one? Okay. All right. Next, we're going to hand it off to Mary to talk about culture of safety.
Okay. Well, as we all know, disability services is a complex system to work within. A lot of times when failures occur, the most common response of care providers is using reactionary approaches, such as discipline or firing, new policies, and retraining. These strategies often have poor outcomes when it comes to improving or making our system safer. Evidence suggests that reactionary approaches may decrease safety. These reactionary approaches are detrimental to staff. There is burnout, turnover, secondary trauma, decreased engagement, and all of these are concerns for provider organizations. Current models of safety management systems engage employees in safety-related efforts. They establish comprehensive approaches to analyzing adverse events and promptly act upon identifying areas of improvement. When typical underlying systemic factors are addressed, provider agencies can begin to make critical advancements in promoting safe outcomes for people served, for families, and for employees. In order to promote the shift to a systemic and a proactive culture of safety, agencies need to be supported in 3 key factor areas and 3 key transitions. First is the transition from a culture of blame to a culture of accountability. Next is the transition from continuously applying quick fixes to addressing underlying systemic issues. And then transitioning from seeing employees as problems to be controlled to a solution to harness. The Disability Services Division has been piloting this culture of safety project in Minnesota for the past 3 years now. I want to review the process that we use to analyze situations such as prone restraint, medication errors, and service terminations. And I'll share some data with you. The next slide. Collaborative safety, culture of safety, really looks at critical incidents from the perspective of the person making the decision in the moment that led to a safety risk. It then analyzes the pressures that the system places on that decision using an access map. We can then pull out themes of where there are barriers or hurdles in our system, and the data we collect from the interviews and mapping sessions are compiled into aggregate data to review. And this is the process here that we use. The critical incident occurs. We have data collection, identifying learning points. We do a regional mapping after we gather information. We create a narrative, complete a scoring tool, and then make recommendations from aggregate data. And if we have the next slide, this is a cumulative summary of systemic themes across 3 pilot counties and 30 cases. There are 2 themes at the bottom with no evidence of influence or substantial influence. These are equipment, tools, and technology and supervisory support. These themes are when there's evidence or substantial evidence. There are system factors that influence decision-making at the time of the incident. The top 2 factors are prescribed practice and cognition. And the following slide describes what this means. If we can have the next slide. So prescribed practice, that's when a practice prescribed by policy or practice standards is absent, conflicting, vague, or doesn't adequately support work. And then 2, cognition, a faulty understanding of a situation due to cognitive fixation or cognitive biases. These are the top 4 themes in critical incidents from our pilot study. These are our systemic influences for lapses in fidelity. We can use this information to better support building capacity. We are looking to expand the number of counties that we work in over the year to come. And now I want to pass it on to Stacy.
Thanks, Mary. All right, I'm going to talk about workforce capacity. So one barrier that we've been encountering repeatedly to offering person-centered positive supports is the workforce shortage, just like pretty much everyone else in the country is experiencing. So we've tried a lot of things over the past several years, and what we have on these slides is nowhere near comprehensive, but we did want to point out a few strategies that we thought other states might want to implement to address the workforce shortage in their area. So the first one is there have been a few law changes, but one that we thought might be relatively easy to get into legislation in any state that we have here in Minnesota requires that service providers consider for the person opportunities for self-sufficiency, as well as developing and maintaining social relationships and natural supports. That's in our 245D law. The next one is we have a stakeholder group that works on the workforce shortage problems, and they developed a work plan for our Olmsted plan. And this group is made up of quite a few different representatives. So we have state agencies, we have people receiving services, we have family members, university representatives, service providers, and advocacy groups. And they made several recommendations on how to address the workforce shortage that we're working on. But their top recommendation has been and continues to be to increase wages, which is not something that we can do as a state department, but it is something that could be done through the legislature. For the next one, a union was created in Minnesota for some types of our direct support workers, and they've been really helpful in pushing forward changes such as the wage increases and also things like improving benefits. Next one is directsupportconnect.com, and that's a website we have that people needing services and the workers who can offer services, they can enter their profiles into the website, and then they can be electronically matched with someone who fits their profile. And then if they look at their profile and say, oh, well, I think that person's a good fit for me, they can request their contact information, and then they can meet and hopefully find a match to get the work done. And then we also have a website for helping people learn about and obtain technology and equipment to support their needs and how to pay for it. We've done some social media campaigns to recruit more workers, and we've also done advertising on places like our public transit system in the metro area. Next one is some workers can receive an enhanced rate after they complete a series of online training courses. And then our last example is a research project that looked into ways to maximize the purchasing power of worker benefits. One example is such as health insurance. So these are some of the things that we've done to address the workforce shortage, but this is nowhere near comprehensive. And if you want more information on that, please send us an email. We can give you some more details and some of the things that we're working on. The next part of our presentation, we're going to talk about next steps, things that we're going to be working towards in the future. And I'm just going to keep going on the workforce capacity. So the first one is a new program that we're trying to set up. It's called Life Sharing. And what this program does is it matches people who need services with people in the community who have shared interests and that would be willing to share their home and time to support the person. So kind of like foster care, but an important piece of this is that we're going to offer an ongoing service to the host person or family to help them fulfill the licensing requirements. Because what we found is that people in the community, they want to help, they want to be supportive of people, but they don't necessarily want to become a licensed provider. So now we would have another provider that I would actually help them with those licensing requirements. And then we'd also have a really robust matching program to make sure that people have shared interests and that they have the same goals and that they'd be a good match to live for living together. The next one is Minnesota passed a law that requires service providers to share data with DHS. And so we're going to start, soon we'll be starting to collect information on staff wages, staff turnover, longevity, and other workforce shortage topics from our service providers. And then once we get that information, hopefully we can make some impact in the workforce shortage, but we've only partially started that this year, and we're hoping to have more of that information this coming year. The next one is Minnesota staff have been partnering with private and nonprofit organizations to share information on how and when it would be appropriate to replace staff with technology or to use technology to ease staff responsibilities. So we found that people, having the website is good, but people need more information and they need more examples. So we've been doing a lot of webinars to show people, how can they use technology, when would it be appropriate or not appropriate to use technology to help with the staffing shortage. The next one is Minnesota collaborates regularly with different state agencies, people receiving services, family members, counties, tribes, universities, and service providers to work on the projects and plan next steps. We found that it's really important to have a lot of different viewpoints and to work collaboratively. So we're doing that now, but we're actually, we have a goal to increase that communication, that collaboration here in the next year or two. Next one is Disability Services Division recently offered grant funding for innovative projects. So for example, one of the projects that received the grant funding is they are going to add disability services as a 4-H career exploration option to the high schools in their area. And then they're going to report to us, see how it goes. And if it's something that is successful, then hopefully they'll be able to spread it across the state and other people will be able to participate in that program. As far as wages, state agencies, like I said before, don't have control over wages, but community groups and advocacy organizations have put forth legislation this year that it's currently being considered by the Minnesota legislature. So we're not sure on how that will pan out, but we should have more information on that next year. And then wages are also listed as the most important topic, like I mentioned before, in our Olmstead Action Plan that was adopted several years ago. And then the last one is transportation is still a big issue for workers, but there is a group outside of our department that's looking into options for transportation. And then for childcare, Minnesota created a website that provides childcare resources. Like we have information online about payment assistance for low-income families. And then we also have like a map. Someone can't find a provider in the area, they can go to this website and they can look up to find a childcare provider near them. Another thing that we're working towards is the simplification, accessibility, and plain language of all of our online resources. So through the technical assistance we provide, we've learned that people often, they don't know where to find information online, or maybe they don't understand the information because there's so much of it. So we've been working over the last couple of years to update all of our web pages, as well as our forums and our trainings. And part of this process is gathering stakeholder feedback. And we actually have a group in Minnesota of several hundred people who receive services, as well as a little over 100 guardians that we actually pay a stipend to get their feedback on items that we plan on publishing. And right now we're short-staffed in people who can put this information online, but we do plan on updating all of our materials in the next 2 years. So if you see something now, please check again later and maybe you'll see some new information. And then for our email system, all of our state emails, not our personal ones, but our ones that are like our positive sports at state.mn.us, they're all connected and we check them daily. And we have rotating staff to check them. So let's say someone reaches out, they contact the wrong team with their question, we can actually route them to the correct team to make it more efficient. They can get the help they need more quickly that way. And the last item is we found that sometimes there can actually be too many resources online. So what we're trying to do is we're trying to simplify our information and we're trying to merge things and make sure that everything works together. And we're also taking old materials offline and combining things so people can find the resources that they need. Another next step that we're working on is expanding intervention services. So we don't only have a shortage of staff, but we also have a shortage of businesses that are offering the crisis, positive support, and specialist services. In addition to that, in regions that do offer these services, we found that not everyone is using them because they're not even aware that they exist. So one thing that we've been doing is trying to offer webinars in hopes of attracting more people not only to provide the service, but also people to use the service. In relation to the workforce shortage, one great thing about businesses offering these services is that it can actually give them a route for promoting staff. So let's say a staff member, they're in college right now, may do direct care for 4 years, but then when they graduate, they could actually start working in one of these specialty areas. So if a provider is offering, both, let's say, foster care, and then they also offer positive support services. That could be a way to retain their staff because we give them an opportunity to promote within their organization. All right, we hand it off to Liz.
Great. So like Mary said earlier, we're partnering with the Institute of Community Integration at the U of M to create communication loops similar to the ones mentioned in Fixing It All. And we're collecting data at different levels throughout the state, and as far as statewide, regional, county, and at the organizational level, at the level of the providers themselves. And the way that this works is that these centers of excellence will have different review processes where they're gathering data on how things are really working, kind of boots on the ground. And then they're implementing plan, do, study, act, continuous improvement cycles, which is essentially an iterative process where it goes, what did we learn? All right, what do we want to do about it? Now let's do it. Now what did we learn from doing that? And coming back around and around to check our practices as we go forward. So really excited about that. So to wrap this up, if you go to the next slide here, what does all this mean for the theoretical basis of implementation science? I think what it comes down to us and the theme from what we've tried to show you about our work here today is that what's really helpful for us is to bring to that conversation is this idea of capacity. What's the ability of people on the ground to implement programs and services? And what's our role in government to really oversee that and assess it? So through workforce, safety science, some of the human-centered design stuff that we're looking at as far as, well, we have all the right resources, but people can't find them. And using that plain language so people can understand our resources has the potential to reduce the need for training and support the ability of folks on the ground to do the work that's so important to them. So instead of really focusing on that train or coach, how are we making things more easier? How are we reducing that response effort for folks that are really doing the work? So I want to come back to the two places and Fixing It All, where I feel like we can add to that discussion as policy folks on that theoretical basis of implementation science. And that first part that I mentioned earlier was, and I'll read the quote again, implementation team members have special expertise regarding evidence-based programs, implementation science practice, improvement cycles, and organization and system change methods. So I'm really proud of the team that we have here. And I think one of the things that we can do is what we're doing now, which is close that policy to research communication loop by telling you guys what we're working on and how we're assessing things in the field. And you saw throughout that we had data that we were using to make decisions. And I think it's important to bring that back to the conversation. So it's not just this one-way loop, the loop also goes the other way back around. I think the other piece about that is the ability of our implementation team to assess environmental conditions that support or inhibit capacity changes the discussion from how do we communicate with policy folks to which variables support or inhibit our capacity. And that's what we're learning in our culture of safety science, and it's super interesting. And if you have questions, we're total nerd. All of us are nerds about it. We're happy to answer your questions. And then last, the one thing that we kind of wanted to challenge in Fixing It All is if evidence-based programs are not being implemented reliably to produce effective outcomes, there's nothing useful to scale up in a state. And so back to the last point I made, that conversely, if we're not taking into account or assessing the environment that service providers are in, we're going to miss that mark. Safety is a really good example. Our providers always want to talk about safety rather than positive supports. And if we don't engage them in that conversation like Amber talked about and really meet them where they're at, then we're not going to get our foot in the door. We're not going to get that buy-in. And so looking at, you know, well, where are the issues with safety and where are these problems happening for you? And then providing positive support suggestions as a way to fix those problems really kind of closes the loop for us. Our providers feel more engaged and we're able to get more work done. And so I just want to see if there's any questions. I think we got 1 minute left. So feel free to pop them in the chat. But we do have further resources. We mentioned a lot of stuff today. We tried to sum up like of 10 years worth of work in an hour, and work with all of our partners. So there's links in our presentation. Our references are in there as well, and you can always email us at positivesupports@state.mn.us. So I will just pause. I think we have 1 minute for questions. No questions. We blew you guys away. They're speechless. All right. Well, thank you, everybody. It's 12:30, so I'm a fan of leaving things on time then. Thank you, everybody, for coming today. We really appreciate it. And again, feel free to reach out to us with any questions.